It's not discussing.
Okay, fine. Okay, so hi everyone and welcome again to our new session. And today we are going to start with the upper limb, right? So in the previous few sessions, we discussed about the embryology. Okay, embryology is session 1 and 2. In embryology, we discussed about the general embryology as well as the development of the heart. So we are done with the basic embryology revision. I advise you, I tell you to kindly go to those sessions and quickly revise those topics. Now, upper limb over here, we are in the first session today. It's a 1 hour session, and let's see what are the topics that we are going to cover. So, hi everyone again, and I'm Dr. Ankit, your anatomy faculty in the Auricle platform, and let's start the session. So, yeah, these sessions of 21 days are beneficial for our mainly for university exams, but I am sure that if you are giving your other MCQ exams as well for the next one, NEET PG is going to be helpful. So let's see some of the topics that we are going to cover. So here are a few of the questions that we are going to cover. Describe the anatomical structure of upper limb. So basic upper limb structure, shoulder area we are going to discuss, brachial plexus we are going to discuss, some of the blood vessels, how do they how do they travel, we are going to discuss about it. Axillary artery, bit of biceps brachii muscle and other muscles also we'll see, and a very important anatomical snuff box. So these are some of the few 5-6 topics that we are going to deal with in the upcoming 50 minutes or an hour or so. Now, why did you use Oracle, guys? These are all the salient features or the USP of Oracle. From it, Oracle actually covers nearly everything, not just the recorded or the live classes, but apart from that, the practical classes, the hard notes, the hard copy notes. We have the express exam module, we have the practical sessions, nearly everything. Okay, these are live classes, express exam module, doubt clearing session. Now, this is something that I don't think anyone else takes note of it, but yeah, Oracle is very, you guys are very lucky, and Oracle is very good over here to discuss about the doubt clearing, because this is very important in our professional courses like medical over here. Hard copy notes, Q bank, practical sessions are there, and these are the subscription plans. It ranges right from the 3 months period to around 4 years, and these are all the packages, the price list over here, and you can use this code below. That is Dr. Ankit 20. Dr. Ankit, my name over here, and you can use this code to avail some of the offers. Okay, okay. Let's move to the topic now. So the topics we have seen over here. What are the various topics that we are going to discuss? These are all the topics that we are going to discuss, and let us move now over here to the topics that we are actually referring to. Now there are a couple of things, guys, over here. What are those? Couple of things over here are that there are some of the to just correlate of what we have studied. We have some of the MCQs that will help you, right? Okay, so I would advise. Okay, first let me help you or guide you guys over here to some of the MCQs over here that might help you guys to understand what we will be actually dealing with later on in the session. Okay, what does it mean? Let me just give me a few seconds over here. Right. So these are some of the few MCQs. Now, what are MCQs? MCQs are multiple choice questions, basically the important topics that we are going to cover. And I'm going to show you some of the MCQs. We are not going to discuss the answers of those MCQs. I'm just going to show you some of the MCQs. I'll just read out the questions for you. You just can go through the options as well. And then we'll come to the session, and then we'll again try to solve the MCQs at the end of the session. I hope that sounds good. Okay, let's see. So over here, the first MCQ, that muscles attached to the area marked in the figure given below. Okay, so you can see the figure, and the options over here are biceps, brachialis, brachioradialis, and long head of triceps brachii. So I'll give you some example. These are some of the examples of how the questions are framed on and how the important topics are over here. So look at the X-ray, look at the bones, and try to figure out. I'm not discussing the answers right now. Just the first example over here. And the example, and the question over here, that you are examining a radiograph of a patient's wrist and note malalignment or dislocation of one of the carpal bones. Which of the following is most likely to be the dislocated carpal bone? Options over here are scaphoid, lunate, triquetral or triquetrum, and capitate. And the example, physician exacerbates means increases. Okay, exacerbate means increases the wrist pain by applying pressure to the base of the thumb as seen in the given picture. Radiographic imaging will confirm a break of which carpal bone. These are all the tests. I'm just telling you the practical importance of this. Options are capitated, scaphoid, hamate, and trapezium. Next question, a patient has suffered a fracture of the surgical neck of humerus. Which muscle is most likely to have been weakened? Deltoid, supraspinatus, biceps, or the teres major? And the example, the pectoralis minor muscle is an important landmark in identifying and describing the neighboring structures in the chest and the axillary region. Which of the following relationships of the pectoralis minor is correct? Now, note down the topic. They are talking about the relationship of the pectoralis minor. Few options are over here. We will discuss them again, but just to show you, questions have come from these topics. Next, which of the following bursa communicates with the shoulder joint? What are bursa? Bursa are your enclosed spaces having some fluid inside them, so that to decrease the friction between the tendon and the bone over here. Okay, some of the bursas are named over here. And the question, a college baseball pitcher has shoulder discomfort and you suspect a rotator cuff tear. I hope you guys must have heard of this term known as rotator cuff. This is a tear of the rotator cuff. You will most likely see damage to the tendon of which of the following muscles? Options here are supraspinatus, infraspinatus, subscapularis, and teres minor. Next question, lower lateral cutaneous nerve of arm. Lower lateral cutaneous nerve of arm. Think about the location. Is a branch of which nerve? Radial nerve, axillary nerve, median nerve, or the musculocutaneous nerve? A 22-year-old lady is admitted to the emergency in an unconscious state. The nurse takes a radial pulse to determine the heart rate of the patient. This pulse is felt lateral to which tendon? Radial artery pulse, radial pulse, very common. Over here, anatomically, they're asking you that this pulse is lateral to which tendon? Options here are palmaris longus, FPL, then flexor digitorum profundus, and FCR or flexor carpi radialis. The boundaries of anatomical snuff box and the high yield topic includes the following except abductor pollicis brevis or extensor pollicis longus brevis or abductor pollicis longus. Okay, so these are all the, note down all the questions over here. Next we have over here, a 36-year-old man is brought to the emergency because of a deep wound on the medial side of the distal forearm. He is unable to hold a piece of paper between his fingers. These are all the practical situations, clinical cases. Between his fingers and has a sensory loss on the medial side of his hand and the little finger. Which nerve is most likely injured? Axillary, median, musculocutaneous, or the ulnar nerve? Here's the image-based question. 50-year-old man falls off a ladder while cleaning the windows, landing on this ground as seen in the given picture over here. He does not seek medical aid, believing his general soreness will go away with the time. That's normally what we do, most of the people. However, after several months, he developed a postural deformity of his left upper limb that includes the adducted, medially rotated, and extended shoulder, extended elbow, and a pronated forearm. So many points over here. The injury and subsequent condition reflects damage to motor structure. So just look at this image and think of what possibly can be there for the injury to the brachial plexus or the nerve of the upper limb. And all these things, adducted arm, medially rotated, extended shoulder, extended elbow, pronated forearm, all that. Okay. And the question from the vessels, an axillary artery has become progressively occluded deep to the pectoralis minor muscle. Which pair of blood vessels, very clinical important question, which pair of blood vessels would most likely provide a significant collateral circulation? You have a collateral circulation around the blockage. Okay, these are all the options. We'll see them again. And the question, just a couple of more, not many. A 64-year-old complains of pain in his right hand and fingers when he works with his hands for a while. Thorough testing reveals insufficient blood flow into the deep palmar arch. Occlusion of which of the following arteries is the most likely cause of this condition? So there's a question from the vessel part. Okay, so guys, these are all the questions. These are all actually the important topics. So we just saw some of the important clinical scenarios over here. Basically, these are all the important clinical scenarios, and that will help us in determining our this uh, the discussion which is going to unfold in the next few minutes. Okay. I hope you saw all these questions. Don't worry, we'll come back again to these questions with the explanation and the answers. Okay. So the topics that we have seen already, let me just describe topics. The general arrangement of the upper limb structure. Very important topic is the brachial plexus or the nerves. Then we'll discuss some of the vessels as well, mainly the axillary artery. We will discuss some of the areas around the shoulder region, okay, and the muscles around it. We also discuss the anatomical snuff box. And when it's a general arrangement, it includes actually the osteology of all the bones over here. Okay, these all is what we're going to quickly revise. Okay, these are 5-6 topics that we are going to quickly revise. Now, just a few more seconds before we begin, let me show you one more thing. In our some of the previous sessions, guys, these are all the topics that we already actually covered, but these are all in detailed. Here you can see the bones of the upper limb that we have been covering and all those topics. So these are all upper limb that the topics that we are going to discuss today has all been covered, like the scapula over here, then you have the humerus, all the osteology in detail over here. So if you are weak in any of these topics, I would advise you go to the previous videos of Auricle YouTube channel over here and then see the relevant topic that you have missed out or you are weak in. Because we have discussed all the osteology over here. You can see all the annotations over here, the bones over here, the phalanges, the nodes, the mammary gland of the breast topic that we will discuss, and all these topics in the pectoral region, the subclavius muscle, all these topics we have discussed. So I would urge you guys just this was the slide just to show you that we have completed before. So if you are confused in any one topic over here, right, then you can actually go to the previous videos and have a good look of it. In the current session, we are going to quickly go through all the important quick revision, rapid revision type of structure. So we'll start with the general arrangement. Okay, now let's come to the topic now, general arrangement. So what we have seen till now the MCQs, okay, all the important topics, and also our, if you are, I mean, the previous session, just a glimpse of it. See, general arrangement, if I start with, it will take just 1 minute over here. This upper limb is actually nothing, but it's an appendage. It's an appendage. Is it important for life? Yes. Is it essential for life? No. You must have seen people in the streets without the upper limb or amputated upper limb. It is important very well. Why? Because all the daily chores that we do, what we do for survival, for job or anything, that is done by the upper limb. Okay, all the work is done by. But is it essential? No. Essential part of the body is head, neck, and trunk. So it's an appendage. This appendage is basically meant for our little bit of mobility and our work. Whatever you do, work is mainly in the upper limb. So therefore, we have a lot of bones over here in the upper limb. That in between the bones, mainly we have the synovial joint over here. Synovial joint movement is required. We have a lot of muscles in this particular part of the body, upper limb, right? Muscles, movement, bones, synovial joints. And obviously for these muscles, you need a nerve. So we have a brachial plexus over here. That is all the nerves. And as it's an appendage, obviously the vessels are required. See, vessels and nerves are required everywhere, wherever we have a living tissue. So I repeat again that upper limb is very important for survival. Remember this basic point. There's no one is going to tell you or no one is going to ask you in any exam, but this is what you need to know. Upper limb or lower limb, both are very important for survival. But are they essential for life? No. Essential? No. Not essential. Okay, while trunk and head neck, these part of the body, they are essential for life. This point should be very clear. Okay, let us see some arrangement now. Now, how many bones are there in the upper limb? Just think about it. Pause the video, think for a second, how many bones are there in the upper limb? If I start with, say, number markings, from the proximal, if we start, then we have a clavicle, okay, in the front. of the pectoral girdle or the shoulder girdle, and then we have a scapula behind. Okay, then we have the humerus, then we have the radius, this is the ulna. Okay, then we have how many carpals? 8 carpals, 1 2 3 4 5 6 7 8. Okay, then we have after carpals we have 5 metacarpals, so 1 2 3 4 5. Then we have 14 phalanges, so 1 2 3 4 5 6 7 8 9 10 11 12 13 14. Yes, so we have 14. So how many bones? 1 2 3 4 5 6, around 32. So I hope we all have the memory of our school time maths classes, that this one refers to 5 number, 4 vertical lines and 1 horizontal line. They are 1 2 3 4 5 6, so 30 plus 2 32. So there are around 32 bones in one upper limb. Total 64 bones in, if you include the two upper limb. Both upper limb will have around 64 bones. Okay, this is the initial, the whole arrangement. Sternum which is attached to clavicle. Now which bone is attached to the this upper limb or the appendicular skeleton? It is the sternum, which is a part of the axial skeleton. Understand this. Sternum is a part of axial skeleton, and that is attached or connected or joined with the clavicle. The scapula has no attachment to the axial skeleton. So sternum will have a joint with the clavicle, and that is known as which joint? Sternoclavicular joint, SC joint. And if I might ask you, because we have done a session on general anatomy, that this SC joint or sternoclavicular joint is which type of joint? It is a saddle variety of, again, synovial joint. I hope the picture is somewhat clear. Let us see some images over here. The entire upper limb osteology in front of you. Do remember the sternum again is a part of, I repeat again, it's an axial skeleton. Rest all is appendicular. Whatever else you are seeing on your screen is appendicular except this sternum part, which is axial skeleton. Clear? And this is the joint over here. If you look at the anterior aspect, the anterior aspect is this anterior view. This is a joint which is connecting the upper limb to the axial skeleton. Which joint is that? That we have already seen. This is sternoclavicular joint. The rest, all the joints over here, going from between the scapula and the humerus, or between the clavicle and the scapula, between humerus and the lateral line, radius, ulna, carpals, metacarpals, phalanges, all those other joints are synovial. Point clear? Let us move ahead. Okay, now this was a basic arrangement. We have seen how many bones are there. Let's move ahead. Now, what is this image showing you guys? Yes, what is this? Here is a break in the clavicle bone. Yes or no? Yes or no? That is one of the most common fractures in the upper limb is a clavicular fracture. But why? Because as you have just seen, it is only this joint over here which is actually transferring the weight transmission from the upper limb to the entire body. So this joint, you can understand the SC joint is so crucial, and therefore the bone over here, the clavicle, becomes very crucial. And as you know that upper limb is mainly meant for movement. That is mainly meant for movement, right? That is mainly meant for movement. Whatever you do, physical work, a little bit of physical work, even if you are um, doing any activity on the laptop or the computer screen, then again the upper limb is needed. Therefore, the clavicle becomes very important, and therefore any injury in the upper limb that will result to a fracture in the clavicle, there's high chances. And you see over here a fracture in the clavicle. So it is one of the most common fractures, remember this, but that is not the point why we have shown this image. That is not the only point. The other point is, if you look at the lateral part of the broken clavicle, you can see that it is going down. Why? Because of this whole weight of the upper limb. Because now the weight transmission is disturbed. It is disturbed because clavicle has been fractured. So therefore, the lateral end of the clavicle is going down due to the weight or the gravity has been written over here. Well, the medial part of the broken clavicle, it is raising above. Why? Because this muscle over here, sternocleidomastoid, which comes from this mastoid process, muscle will go into spasm and it will pull it up. So there is more gap in between. If I try to show you the gap, there is more gap in between. Why? Because the one part of the bone is going down, one part of the bone is going up. So therefore, fracture of clavicle needs treatment, and it is one of the most common fractures, and it needs treatment. If you leave it like this only, then there will be malunion. Malunion means the bone will be might get close to each other, but they will be malaligned. There will be malalignment. Alignment would not be good. Try to understand. And this is one of the most common bone to get fracture. Therefore, questions come from this star mark, clavicular fracture. Okay, so general arrangement clear. Now let us see one more radiographic image just to show you the bony arrangement around the shoulder region. Just one sample over here, nothing much. Here what you can see is you are seeing this as the humerus over here. This as the CLA dot clavicle over here. And what is this? This is SAP dot scapula. Here, if I just encircle this area, which joint is this? This is the shoulder joint. Do remember, this is the shoulder joint. And it is one of the most common joints to be dislocated. D oblique L is dislocation. One of the most common large joints to be dislocated is the shoulder. Why? Because shoulder joint, we all know it's a ball and socket, right? The ball is quite big and the socket is small. Therefore, the ball sometimes, or in many or injuries of very low intensity, the ball over here, this is ball, this is socket. The ball over here slips away from the socket. Therefore, it is one of the most commonly dislocated joint, as you can see over here. Theoretically, let me tell you, the surface area of this ball over here is 4x than the surface area of the socket. 4 times. Ball is around 4 times surface area than that of socket. You can understand why it would slip around easily. Okay, just a image over here and showing you all the important features. Even if you have, if you want, then you can take a screenshot of this and just look at all the labelings over here. That's important. Okay, now general arrangement clear. One more image over here. Why? Because just to show you humerus. But sir, why we are seeing humerus? I'm not going to teach you the entire humerus because that will take in itself entire 1 hour. But in this image, I'm going to tell you about these 3 nerves: axillary, radial, and ulnar nerve. Why? Because they are practically important and therefore questions do come. Practically important. What does it? It means that these 3 nerves, the axillary, the radial, and the ulnar, they are very close or they are in contact with the bone. So what is the problem? The problem over here is that if you have, for example, say axillary nerve, it is close to the surgical neck of humerus. What part? Surgical neck, or the upper part of the humerus. So if there is a fracture in this particular bone, this nerve is prone to be damaged. Similarly, radial nerve is close to the mid shaft of the humerus. So if there is a fracture in this mid shaft, and it is common, then there can be problems with the radial nerve. And this ulnar nerve, it goes just behind the medial epicondyle. This part over here of the humerus is known as the medial epicondyle. So if there is a fracture in the medial epicondyle, there might be problem in the ulnar nerve. So do remember, axillary nerve, radial nerve, and ulnar nerve, they are very close, in very close contact to the bone humerus. So there will be a lot of questions and a lot of clinical cases. When there is a fracture of the surgical neck of humerus, fracture of the shaft of humerus, medial epicondyle, fracture or dislocation, something like that, then these nerves are prone to get damaged. Remember this. Okay, here's the image. Next image. Just to showing you the interosseous membrane between the radius lateral side and the ulna on the medial aspect. If I ask you this is which type of joint, what will you answer? If you remember our first session on the general anatomy revision part, this is the fibrous variety, interosseous membrane. Just the image over here to let you remember again about this fibrous joint. Now, last point over here from the osteology is about this hand radiograph, hand X-ray. In hand X-ray, very easy, you can look out the phalanx, no problem about it. If you see the 2 phalanx, that is the thumb side, it has 2 phalanx, and others have 3. The distal, the middle, and the proximal phalanx. Fair enough. Similarly, you can easily count the metacarpals. Low down if you go, then you can look at the radius and ulna. On the lateral side, if you are seeing the thumb, you are seeing the radius. Okay, secondly, understand the radius lower margin is quite broad compared to ulna. It is nearly twice as broader than the ulna. The main issue over here is not showing you the phalanx in the metacarpal. The main issue is telling you about the carpals over here. Carpals, do remember, we have a mnemonic. If you go from, if you say this side, lateral to medial side, a proximal row PR and a distal row DR. Okay. Proximal row PR and a distal row DR. Lateral to medial. Mnemonic is she looks too pretty. Okay, try to catch her. I'm sure most of you or nearly all of you must have heard about this mnemonic. So she looks to S over here determines scaphoid. L over here is lunate. T over here is the third bone. If you go count, that is triquetral. P is a sesamoid bone, pisiform. Again, T over here is trapezium. Second T is a trapezoid. Catch C is capitate and H over here is hamate. So do remember all these carpals over here, all these 8 carpals with the pisiform being a sesamoid bone. Okay, do remember the pisiform over here. The pisiform I'm writing over here, pisiform is a sesamoid. What is sesamoid bone? Sesamoid bone are the bones which are found in the tendons of the muscles. So somehow they might ask you, okay, you know the definition. Can you name the tendon from which pisiform is formed? If you know, guys, write in the comment box. If you're hearing this, don't hesitate to write in the comment box right now. The tendon over here is our flexor carpi maris. Okay. If you know it, very good. So do remember this. Next, we move ahead and we come to our this one topic over here, though it was not part of the our small questions, but remember this clypectoral fascia. I am sure for all those who are going to give the university exams, you must have heard about this. This is one of the most frequently asked questions in both theory as well as practicals. Even in practicals, yes. So clypectoral fascia is actually a component of a deep fascia between what? Between clavicle and pectoral muscle. Now question comes, okay, sir, which pectoral muscle? Is it pectoralis minor or major? That I will leave up to you guys. If you want to think, pause the video and think about it. We are saying clavipectoral fascia. We are saying clavipectoral fascia. So is it pectoralis minor muscle or pectoralis major muscle? That is the point. The muscle over here is minor, not major. So this fascia is between the clavicle and P minor muscle. Do remember this. So is that the question that they ask? They might ask, but apart from this, what they do ask is also what structures pierce it? What structures pierce it? So very small but a beautiful question comes. What structures pierce it means what structures pierce the clypectoral fascia. So in this image is actually a sort of parasagittal section. Suppose I'm sitting like this and there's a section going like this, parasagittal section. So this image is sort of parasagittal section, parasagittal, let me write PA para also. So in this image, if you look at the clavicle, this is the clavicle and this is the P minor over here. This fascia over here in between, that is the clavipectoral fascia, clavipectoral fascia. And these are structures that pierce it. How to remember the names? Because that is very, here I would advise you go with the mnemonic. Structures piercing, written. The mnemonic over here will be CALL, call. C refers to, as you can see, cephalic vein. Okay. A refers to acromiothoracic artery. And 2L are over here, lateral pectoral nerve and lymphatics. So here I will advise you to actually go through the mnemonic CALL. That might be helpful for you. Okay. So CALL, C for your cephalic vein, A for this is a vein over here. This is an artery over here. That's a nerve over here. And that's a lymphatic over here. These are the structures that will pierce the clavipectoral fascia. And this between clavicle and pectoralis minor. Do remember that also. Okay. Okay, one important question done over here. Mnemonic done over here. Keep that in mind. Okay, let's move to one more topic over here. And a bit of vessels. And particularly here we are discussing the axillary vessels, but I will tell you a bit of more vessels. So let's talk about the vessels in general. How the vessels reach the upper limb. Forget about that image. I'll tell you from the beginning. From the beginning, if we see, then imagine this is the heart over here. Okay, here is the ascending aorta, here's the arch of aorta, and the descending aorta. The arch of aorta gives off a brachiocephalic trunk, which divides into right subclavian and right common carotid. Then there's a left common carotid and left subclavian. So let us label it later on. So what happens to let's see on the right side. So this is right subclavian over here, arrow, and this becomes the axillary artery, then passes through the axilla, and then it becomes a brachial artery. It passes through the upper limb, that is the arm region, then divides into radial and ulnar artery. They'll pass through the forearm, and then finally they'll end in the arches of the hand. This is the whole picture. Now let us label it. Let us label it. This is the heart, that is the arch of aorta. This is BCT's brachiocephalic trunk, and this arrow was right subclavian artery. Now here is one structure, if I may try to show you over. What is this? So this is some, looks like a rib. Very good. This is the first rib. So the moment this artery crosses the first rib right from this point, we will call it as the right axillary artery. Do remember this. It runs in the axilla. Now, sir, if I don't know anything about the axilla, then after finishing this video, I would urge you to go to the previous videos where we have discussed axilla in detail. Now this axillary artery is going to pass through the axilla, and once it passes through a particular muscle, which muscle? Teres major muscle. Once this artery passes through the lower border of teres major, then this artery becomes right-sided because we are dealing with the right side, brachial artery. Which artery? Brachial artery. That will run through the arm. Once it crosses the elbow region or the lower or the head of the radius, this divides into radial artery on the lateral side and the ulnar artery on the medial side. That's a whole scenario, basic scenario. The similar thing happens on the left side as well. Therefore, we discuss only one side. Okay. Now see what happens is the in the axilla, this is the region of axilla. Let me highlight actually the axilla over here. This whole is the region. Imagine this whole is the region of axilla. Axilla has a lot of lymph nodes, axillary group of lymph nodes, axillary vein, axillary lymphatics. So here, any structure can come and compress the vessels. Okay, in that case, what actually happens is logically or naturally, there are few of the branches of subclavian and axillary artery that anastomose around a bone over here. And that bone is the scapula bone. So what happens is that there is a lot of what? There's a lot of normal anastomosis of the arteries or the branches of the arteries around the scapula. But when there is any obstruction, right? Just imagine that there's some tumor growing in the axilla, or there's some axillary lymph node enlargement due to carcinoma breast. Now, breast carcinoma, as we must be knowing, is the commonest cancer in the females worldwide, not just India, worldwide. So in the breast cancers, the axillary lymph nodes, they get enlarged. And if axillary lymph nodes are scattered over here only, where else they will go? They're in the axilla. They might compress this artery. In those situations, these collaterals or these anastomosis, they play an important role. Now, sir, why do we need anastomosis? If you're thinking, okay, why? Because it's the only artery that's going through the upper limb. If it is constricted over here, then the upper limb will die. Die means all the tissues over here will actually die. They will necrose. So therefore, we need anastomosis. This is the axillary artery over here. You understood the importance? Now, it is so important that what we did is that we have a muscle over here, and that divided the axillary artery into three parts. The first part, the second part, and the third part. What is first, second, third? The first part is before the muscle. Second part is of the artery is behind the muscle, and third part of the artery is after or distal to the muscle or lateral to the muscle. Can you think of which muscle is this? Which muscle divides this axillary artery into three parts? You can pause the video and think if yes, and if you're not lazy enough, do type in the comment box as well. This muscle over here is the muscle pectoralis minor muscle, the same muscle that we talked when we were discussing the clavipectoral fascia. This muscle divides the artery into three parts. Now, if you understood the basic scenario over here, then we can look at the image over here. This is the region of the axilla having the axillary artery and the axillary vein over here. Next image over here is showing you the axillary artery divided into first part, second part, and third part. And which muscle is over here? Let me highlight it. I'm sure you got the name, but again, let us highlight this name over here, pectoralis minor muscle. It is dividing the artery. So axillary artery, then comes a question from the axillary artery. Okay, fine, that you have said it is divided in three parts. What are the various branches? Now, branches is something that we need to have some basic common sense plus some idea. From the first part, we have one branch. From the second part, we have two branches. From the third part, we have three branches. Total how many branches? 1 plus 2 plus 3, 6 branches are there. On the first part, we have one branch. Now, which branch will it be? It is the branch that is very, it is the upper part of thorax. So we call it a supreme or superior thoracic artery. In the second part, we have two branches. One is the acromiothoracic artery. I sure it in this name might have ringed some bells in your mind. The same artery that was piercing the clavipectoral fascia. And the other branch is the lateral thoracic artery. The third part has three branches. One is the subscapular artery, and the other two are anterior and the posterior. Circumflex humeral artery. Circumflex humeral artery. Don't worry, you'll see in another image over here. These are the some of the important branches over here. Let me show you the subscapular, the circumflex humeral arteries. Right, these are some of the branches from the axillary artery. These were some of the branches. Now, anastomosis we discussed in this image, the anastomosis. Okay, there's also going to be a question. Now, anastomosis around the scapula, it occurs between which arteries is the question, theoretical and practical. Now, before axillary artery is a continuation of which artery? Axillary artery is continued from the subclavian artery. So what actually happens in the scapula anastomosis is there will be one branch from the subclavian artery, proximal part of subclavian, and one branch from the third part of axillary artery. They are the ones that are actually anastomosing around the scapula. Do remember it is subclavian. So therefore, if there is any obstruction over here that we were saying previously, then the blood from here will actually go like this and will come to the upper limb. Blood from here will go like this and will come to the upper limb. So the blood. So if there is a problem in the axilla, the upper limb should get its blood supply. That is why we have anastomosis. Okay, in this image, you are seeing some of the few anastomosis over here. Let me highlight the anastomosis. Okay, we have the subscapular artery and its branch circumflex scapular artery. These are branches on the axillary artery. We have highlighted with the yellow color. Now, if I change the highlighter color to the green color, okay, here we have suprascapular artery, and here we have one more artery. Let me write its name first, then we'll highlight this name over here. That is dorsal scapular artery. Which artery? Dorsal scapular artery. So this green highlighted thing over here is representing the branches of subclavian artery, and this yellow highlighted is telling us the branches of axillary artery. And what are they both denoting? They both are denoting the anastomosis around scapula. That is another highlighted topic over here. I hope you understood this. Yes or no? Let's move ahead. This image is showing us the axillary veins over here. The axillary veins, they run medial to the axillary artery. But what is this image showing us, and why I've kept this image for your quick revision is look at all the nodes, guys. These are all the nodes. Just understand how many nodes are there. And here we have the breast tissue, which is a very commonly affected by carcinomas, and those carcinomas are carried by these lymph nodes, and these lymph nodes might get enlarged and matted and fused with each other. That can easily compress the artery, not totally compress, but even a bit of compression of the artery can decrease the blood supply going to the upper limb. Therefore, we have to know these anastomosis. Okay, these anastomosis, what we have seen just now. Okay, and this is a continuation of the axillary artery. So this image is just showing you axillary artery continues into brachial artery, which divides into radial artery and the ulnar artery over here. Right, as we just discussed about it. Okay, this is just an image over here. This image is also telling us the same thing, brachial into the radial artery and the ulnar artery. Now this image is actually telling us one more thing. You can take a screenshot of it and then see all the branches. It is showing us another anastomosis, but this time not around scapula anastomosis. This time is around the elbow region. There was around elbow also we need, but sir, why? Because understand, no, there's only this one important vessel that is running. And if this is compressed, suppose you just bend your elbow, you flex the elbow, and this artery will be compressed. How will the blood reach the hand? There will be a problem, yes or no? Therefore, we need some arteries on the sides. Let me highlight this. Let me highlight the anastomosis actually. These are all the anastomosis that is happening on the sides of the elbow. So that once you fold your, or once you flex your elbow, the blood does not decrease going distally into the forearm of the hand. That is why we need anastomosis also around the elbow. So it's all normal. It's not that we have the compression only, then no, it's all normal. It's all normal. Next, we move ahead. Now we come to the nerve part. Now we come to the nerve part. Very, very important nerves part over here. In this image is showing us all the important dermatomes. What are we seeing? We are seeing all the important dermatomes over here. Okay, the C5 to T1. If you just recall, you'll see the brachial plexus, but brachial plexus is basically from C5 to T1. We can have a prefixed having a C4 or a postfix having a T2 as well. Okay, let's look at the anterior view and the posterior view and look at all these shadings. Okay, here we need to know something, right? This is upper lateral cutaneous nerve of arm over here. Look at the color matching. Okay, then we have a lower lateral cutaneous nerve of arm here. Let me match the color. And we have a lateral cutaneous nerve of forearm over here. Okay, these three color matchings are important. We have the median nerve, that is also important, and we have the ulnar nerve, that is also important. This is the anterior view. Just think about it. The medial cutaneous nerve of arm, forearm, they are directly coming from brachial plexus, medial cord of brachial plexus. On the posterior aspect, if you see, then this yellow color is important. It is superficial branch of radial nerve. Right? Now try to understand what we need to understand over here. Very, very importantly, is this upper lateral cutaneous nerve of arm. This area, this is actually a branch of axillary nerve. Remember this. This lower lateral cutaneous nerve of arm only. It's a branch of which nerve? Radial. There are three important questions I'm telling you. And this lateral cutaneous nerve of forearm, it's a branch of which nerve? Musculocutaneous. Let me write the entire name, musculocutaneous nerve. So do remember on the lateral aspect, we have axillary nerve, radial nerve, and musculocutaneous nerve. You can remember it by the mnemonic. What is this mnemonic? I am sure very easy to remember. ARM, arm. Okay, so do remember the arm over here. Let me highlight it. ARM. ARM is the arm over here, and this arm refers to what? The axillary nerve, the radial nerve, and the M is not median, it is musculocutaneous. And do remember in the hand also. In the palmar aspect, we have the median nerve on the lateral side and the ulnar nerve on the medial side. On the back side of the hand, or the dorsum of the hand, laterally, on the thumb side, laterally, we have the radial nerve. This is the radial nerve over here. So do remember these 3-4 points at least on this particular image. Questions pops out from here. I've just shown you the brachial plexus. I'm sure this image you all must have seen. You should know actually in the examination hall how to draw the brachial plexus. But sir, it is very complicated. No matter what, practice it. Mnemonics I've told you, they start with the roots, then their trunks, then their divisions, then their cords, then their terminal nerves of the branches. Mnemonic we have done in detail. Right to drink chilled beer. Right to drink a slightly funny mnemonic, but yeah. Right to drink, C for chilled. And this is actually the branches, terminal nerves of the branches over here. So branches we say beer. Right to drink chilled beer. So root, trunk, division, cords and branches. Ranges from C5 to T1, and then you have all these images. How many roots are there? What are the branches of roots? So in the brachial plexus, what is must know is, first of all, diagram you should know. Labeling should be clear, guys. Practice it. How many times? Be it 20 times, 50 times. 50 times is max upper limit, no? We just try to draw it for 5-10 times, things will be clear. So diagram labeling, okay, labeling all the branches should be clear cut. Okay, you should know where to draw the root, trunk, division, cord, and branches, all of that. And all the three cords, you should know what are their branches. What are the three cords? Medial, lateral, and posterior cord. Their branches. Medial cord has 5 branches, lateral has 3, posterior has 5 branches. Even the roots and the upper trunk, they have branches. Roots and the upper trunk, they have branches. So going on like this. Let me highlight few of the important. Actually, everything is important in this brachial plexus, so it becomes very hard to highlight. So these 4 over here, these 4 are the branches from the root and the trunk. The rest, all this 13 are coming from the cords. 13 over here are coming from the cords. Okay, we are not going to discuss the entire brachial plexus. It's in itself a 2-hour topic. Now, something important over here is again a brachial plexus, showing you that how we have named the chords, because this brachial plexus, it is around which vessel is this? This which vessel in the axilla, on which artery in the axilla? Axillary artery. Yes. So brachial plexus is wrapped around. It is actually wrapped around the axillary artery. And the naming of the chord, that sir, which particular chord we should call it as lateral medial posterior. The labeling or the naming of the chord of brachial plexus is related to the second part of axillary artery. Which part? Second part of axillary artery. If I ask you this second part, it lies before the P minor muscle, after P minor, or behind P minor. What will be your answer? You can pause it and think and even write in the comment box. The second part of the axillary artery will be, yes, behind P minor. It is behind pectoralis minor muscle. So if you reflect the P major, first of all, you cut the skin fascia over here. You see the P major, you cut the P major, reflect it. Then you have seen the P minor, reflect it. Just behind P minor, you'll see a vessel, and around it, some of the whitish cords. If you look at their relation to each other, then you can name it as lateral, medial, and posterior. Do remember it, as is shown in this particular image. Now, this image, I'm sure you must have seen that MCQ also that we were trying to discuss, that MCQ, right? Here you can see the undue separation of the head and neck. Here, the upper trunk of brachial plexus is involved. Which trunk? Upper trunk. This leads to Erb's palsy. Erb's palsy. Erb's palsy is upper trunk. What is upper trunk? C5 and C6. And in the Erb's palsy, again, it's a detailed topic, but let me just tell you over here. The three nerves are mainly involved. Mainly, the mnemonic is SAM. The three nerves are mainly involved. SAM. What is SAM? S is your suprascapular nerve. A is the axillary nerve. Axillary nerve. And M is the musculocutaneous nerve. These three nerves are mainly involved when this sort of injury, when there is separation of neck and shoulder, undue separation, either in the breech delivery, excessive stretching, or not in normal delivery, excessive stretching on the neck, or when the person falls down on the side of the head. Erb's palsy. Second palsy over, this is the attitude of the, this is also known as policeman tip hand, or porter's tip deformity, right? This is the attitude of the limb in Erb's palsy. Erb's palsy, the attitude of the limb looks like this. You see again in the MCQ. And this sort of injury over here is when someone is falling and clinching onto the branch of a tree, or the hand presentation is there in delivery, hand is being pulled. This is the lower trunk involvement of brachial plexus when C8 and T1 are involved. And this sort of palsy is known as Klumpke's palsy. Here also you'll see the clawing of hand. The clawing of hand is also seen over here. Do remember this. Okay. Okay, let us move to the some of the muscles around over here. Again, this is the back region. Just to name a few muscles, there's a trapezius over here. Okay, this is your latissimus dorsi over here. That is teres major below, right? This would be a sort of say infraspinatus. That will be the deltoid muscles. Some of the muscles just over here. These are all the movements around the scapula, or the movements around the shoulder region. The movements around the shoulder region are being displayed over here. Elevation, depression, lateral rotation, medial rotation, abduction, adduction, all those movements are being shown over here, and the muscles relevant to it. The shoulder region, we have a shoulder joint in itself, a complete different topic. I would advise you, it is the most important joint being asked with 4 stars for this. Go through the entire video on the shoulder joint, understand it. What are the bones involved, the ligaments involved, the movements, the muscles, all those involved in the shoulder joint. Very, very important. So whenever a question of the joint will come, you have to write few types. Well, you have to write few subtopics of the joint. For example, which type of joint it is. What are the bones involved in it? Yes or no? What are the various ligaments that are found in the joint? Right? What are the various movements of the joint? What are the various muscles involved in movement? This I'm telling you from the perspective of any joint. And this shoulder joint is the most commonly asked joint in upper limb because it is the largest joint in upper limb. Most mobile joint in upper limb, ball and socket variety. And finally, don't ever finish your anatomy answer without telling about the clinical anatomy or clinical scenario. Be it just 2 or 3 points, but you should always end with this. This is the entire basic, entire, output of your theoretical knowledge. See, you are reading so much of theory, you are learning so much of things, you are writing so many things. But unless and until you present it in a clinical way, what's the use of this? I hope you're getting a point. This is what the examiners, the teachers, the faculty needs from you. This is what is actually correct. This is not only what the faculties needs from your answer, but this is what you also need from you yourself. So always end your answer with a clinical anatomy, be it any topic. Okay, I'm just telling about the joints, and always see, needless to say, diagrams. Needless to say, diagrams over here. Let's move ahead. This is the rotator cuff. Rotator cuff. Rotator cuff over here has 4 muscles. I will show it like this: SI, small t, and again S. What is this 4 muscles? I hope you can see the supraspinatus, the infraspinatus. Small t is for teres minor, and another S is for your subscapular. These are 4 muscles that encircle the shoulder joint and increase its strength. And most commonly injured over here is supraspinatus, because it actually lies deep to the coracoacromial ligaments. Actually, it is compressed between the bone and the ligament. Most commonly injured is supraspinatus. It has some tears in it, a complete calcification of it, a complete tear, incomplete tear. There's so many no this clinical scenarios of the supraspinatus muscle. Okay, this is a carrying angle. I hope you know about the angulation between the arm and the forearm. Okay, just an image. I thought just to show you, just to make you remember. It is more in females than in males, because in textbooks they write females have a wider pelvis. So once the females have a wider pelvis, so obviously the upper limb carrying angle will be a bit more evolutionary on the evolutionary perspective. Okay, here we have when the topic that we are discussing is the biceps brachii muscle. So biceps brachii, will just take 1 minute from the biceps brachii. Biceps means two head. There is a short head and there is a long head. Both will come down, insert where tendon inserts into the radial tuberosity. Remember this. Also gives off a bicipital aponeurosis. That is very important when you refer to the cubital fossa. But tendon, if someone asks you where does the biceps insert, sir, into the radial tuberosity. Fair enough. Now about these two heads, the short head comes from the coracoid process of scapula. If I may show you, this is the region. This is the coracoid process of scapula. The long head, it comes from the this is the long head. It comes from the supraglenoid tubercle. Supraglenoid tubercle, again, of the scapula only. So both these short and long heads, they are coming from the scapula. Then they fuse and they form a bulk flash of the muscle, and then that tendon goes into the radial tuberosity. What these muscles do is basically flexion of the arm and forearm. Arm and forearm plus 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 plus. There's one more action of this muscle. Pause the video and comment if you know the answer. The another action of this biceps brachii muscle is supination. Very important, supinator. And if I ask you, okay, can you tell me what's the nerve supply of this muscle? Yes, it is the axillary nerve. Yes or no? No, it is not axillary nerve. Axillary, I'll tell you what it supplies. That is also important. But this biceps brachii muscle over here, this biceps brachii muscle is supplied by musculocutaneous nerve. Which nerve? Musculocutaneous nerve. Now, why I place this axillary nerve over here? It is very important. See, biceps is just an example over here. Whenever the muscle comes, always remember to write its origin, insertion, nerve supply, action. Must. And if possible, in the end, again, clinical scenario. Any muscle. Which muscles will come? The larger muscles, like the biceps over here, and other muscles that can come is deltoid. So axillary nerve supplies deltoid muscle actually. Also, it supplies teres minor. Therefore, it places axillary nerve. Other muscles that can come, just think of it. Triceps can come. Pectoralis major can come. These are big, big, huge muscles. Trapezius can come. Latissimus dorsi can come. So all these. So any muscle, origin, insertion, nerve supply, action. So, but how to remember the origin insertion? See, guys, if you don't know the exact particular point where the muscle is originating, give the examiner an approximate idea. That is enough. But nerve supply and action should be clear. And finally, clinical applied. What happens if the muscle gets paralyzed? When will the muscle get paralyzed? What happens if it gets paralyzed? How will the patient come to you? Okay, a lot of things can be told from there. This is again a cadaveric image showing us the two heads of biceps brachii muscle over here. Last topic, not the least, we have the anatomical snuff box. This is one of the questions that has been coming since many years, every year, not just your university exam, not just university exam, but even in all the PG exams. There's been coming. Anatomical, if you extend the thumb, you'll see a concavity over here. Okay, that was used for snuffing. That's why it is known as anatomical snuff box. The boundaries of it are frequently asked. Now, to remember the boundaries, there is a lateral boundary and a medial boundary. So, what if the theory question comes to you? What you can write apart from the images, you can talk of the boundaries. Then, after boundaries, you can talk of the roof. Okay. Then you can talk of the content. Then you can talk of the floor. Finally, clinical is obviously important. These are all the things that can be written about. Now, boundaries, when we say lateral boundary, we have APL EPB tendon. What is APL EPB? Abductor pollicis longus, extensor pollicis brevis. And the medial boundary by extensor pollicis longus tendon. These are three tendons that form the boundaries. The roof is basically the skin fascia, but in the roof we have a cephalic vein as well as a superficial branch of radial nerve. Content is only one content, that is the radial artery. That is the radial artery. Floor, we have the bones on the lateral aspect, like the lower end of radius, the scaphoid, or the base of metacarp, first metacarpal, all that will be the floor. Clinical, obviously, any fracture in this region of all these bones, pain in the anatomical snuff box. Then those tendons may have the tendinitis, again the pain in the anatomical snuff box. So it's an important scenario. If we just see this image, then let me just cross hatch. This is the anatomical snuff box. These two tendons, extensor pollicis brevis and abductor pollicis longus, they are which boundary? Lateral. And this extensor pollicis longus over here, that is the medial boundary. You can see the radial artery, that is the sole content of the anatomical snuff box. So this topic, guys, is very important. It's a small topic, but very important. Okay. So this was the last topic. Now let me again go back to the MCQs and just quickly in just 4-5 minutes deal with all of your MCQs, and let us see. Okay, there were around 10-12 MCQs over here. Let us quickly go through them and just highlight it. Okay, so first MCQ, muscle attached to the marked area in the figure below. So this bone is the radius. This is the radial tuberosity. Which muscle is attached to the radial tuberosity? Biceps brachii. See how the questions can be asked. The arrow is towards the radial tuberosity. Next question. Radiograph of the wrist and note a dislocation of the carpal. Which carpal bone is commonly dislocated? It's a factual sort of question. Always do remember, lunate is the most commonly dislocated carpal and scaphoid is the most commonly fractured carpal. And this is a DL, dislocated carpal. Next question. Pain is increased by applying pressure to the base of the thumb. Which carpal? So most commonly fractured bone we just saw is scaphoid and also lies on the lateral aspect. Thumb is on the lateral side, as you can see in the image. Answer will be scaphoid. Patient had suffered a fracture where? In the surgical neck of humerus. Which muscle? Surgical neck of humerus, which was the nerve? Remember that humerus image, axillary nerve was the nerve. It supplies two muscles, deltoid and teres minor. Answer. So guys, if you know the concept, you have the knowledge, answer is very easy. The pectoralis minor muscle is an important landmark in identifying and describing the structures. Which relationship of pectoralis minor is correct? Okay. The lateral cord lies lateral to the muscle. Not the muscle, but lateral cord, when we say, then it is lateral to the second part of axillary artery. Anterior axillary lymph nodes are over here. Lateral wall of axillary fossa includes the muscle, not the lateral wall of it is the anterior wall of axilla. The second part of axillary artery, yes, it is the second part of axillary artery that lies deep to the muscle. Remember, 1, 2, 3, 3 parts. Answer is option number D. Which bursa? Yes, it's again a factual question. It is a subscapularis bursa which directly communicates. Subacromial bursa is the largest bursa of the shoulder, but not the answer in this MCQ over here. A baseball player has a shoulder discomfort and you suspect a rotator cuff tear. You will most likely it was which tendon? Supraspinatus should be the clear-cut answer over here. Simple. Lower lateral cutaneous nerve of arm. So it was ARM. What was this? The mnemonic. This was the upper lateral cutaneous nerve. This was the lower lateral, and this is the lateral cutaneous nerve of forearm. What they're asking you, lower lateral cutaneous nerve of arm. Lower lateral is this. Answer is R for radial. Do we have an option? Right. A 22-year-old lady is admitted to the emergency in an unconscious state. Radial pulse. A pulse is felt to lateral twist. And do remember over here that we have a mnemonic ALT, that is arteries lateral to tendon. Same name artery, radial artery. Same name tendon is flexor carpi radialis. Should be the yes answer over here. And if you take it on the other manner means if it is the ulnar artery, then it is lateral to flexor carpi ulnaris tendon. Do remember this also. The boundaries of anatomical snuff box include the following except. So lateral boundary was abductor pollicis longus, extensor pollicis brevis. Medial boundary was extensor pollicis longus. Now we know the whole theory. Answer is therefore in front of you. Out of 4 options, which one would be the answer? Abductor pollicis brevis would be the answer. And right. Man is brought to the emergency because of a wound in the medial side of the distal forearm. Over here, he is unable to hold a piece of paper between the fingers. So there's loss or there's weakness in what? Adduction. There is problem in where? Problem in adduction of the fingers. Okay, adduction is in which muscle? That is something in the hand, interossei. Sensory loss on the, so this is what we saw today. Sensory loss in the middle side of the hand and little finger. Which nerve was there? If we only take this point, ulnar nerve should be the answer. Simple as that. Okay, and the interossei also supplied by the ulnar nerve. That confirms the answer. This image telling you which palsy? Of palsy. Even before reading the whole question. Of palsy is the palsy of which trunk? Upper trunk, upper trunk, upper trunk. I don't know what they have written the question. Suppose you have 10 seconds left in your PG exam, last question, and you're seeing this image, seeing the option. You don't need to read the entire question. Just read the last line. The injury and subsequent condition reflect damage to what is upper trunk. Tick. Option A. Click on it. Submit the paper. Done. Right. The axillary artery has become occluded due to the P minor muscle. So it is the second part of axillary artery that is occluded, which pair of blood vessels. So it is anastomosis around scapula. So if you remember suprascapular, subscapular, and dorsal scapular, circumflex that will be, so we have options over here. Writing down answer is subscapular from axillary artery and suprascapular from subclavian artery. That will be our answer. If there are other options, if you see, they don't fit into it. Last question over here. Pain in the right hand fingers when he works with his right hand for a while. Testing reveals insufficient blood flow to the here we can help them. So what happens is in the hand there are 2 palmar arches. Arches means suppose this is the say the lateral side over here and the middle side over here. So we have which artery? Radial artery, and over here we have the ulnar artery. There are 2 arches, superficial arch and the deep palmar arch. Where? In the palm, because both are palmar arch. Imagine this is the area for the palm. This is palm. So lateral side we have the radial artery and middle side we have the ulnar artery, and they both form the arches. Now, which arch is basically contributed by which artery? That we can remember by simple mnemonic. You not all of you guys are becoming doctor. Doctor we write DR. So deep arch is coming from radial artery. Here the problem is in the deep arch. Answer has to be the radial artery. The superficial arch is mainly contributed by the ulnar artery and deep arch by the radial artery. I hope this is really simple, right? So these were the MCQs, these are the topics. I hope we have touched on a lot of topics today, and I hope you enjoyed. Let's see in the next session tomorrow, or maybe whenever you have the next session, what are the things that we do. Revise it, and any issues, let us know in the comment box. That's all. Bye-bye, and be ready for the next session. Thank you.